And I especially want to thank both Catherine Tan and Ed Ryan. I'll introduce Ed first, and then I'll introduce Catherine Tan. This is a collaboration between IDSA and also GTEN, which I'm going to tell you about in a few minutes, which is a CDC-sponsored program. And Ed, you'll probably talk a little bit about it also. So we're going to start the hour, and we broke it up into 30 and 30 minutes, talking about the treatment of malaria in a non-endemic region. And Ed Ryan is going to tackle that topic. And then Catherine Tan is going to talk to us about CDC's experience with artesunate. And I know a lot of us are anxious about that because we no longer are getting artesunate through CDC. And I know here in New York City, we see a lot of malaria. And so I see a lot of ID people popping on the call. And so we really do want to know about this. So this is timely. We know, I think a lot of you can't raise your hands, but a lot of us are seeing a lot of malaria and return travelers. People are traveling, and we're seeing a lot of our Africans going back and traveling to go home. And so at least here in the Bronx, that's who we're seeing with malaria right now. So we'll start off with Ed. Catherine, I'll then introduce you. Ed Ryan is a professor of immunology and infectious diseases at Harvard T.H. Chan School of Public Health. He's also a professor of medicine at the Harvard Medical School and director of global infectious diseases at the Mass General Hospital. He's got a long CV, and I know he doesn't even want me to read it. He has NIH-supported work, which does focus on, for the fellows, host pathogen interactions and enteric vaccine and diagnostic development, but his CDC work is really looking at both malaria and return travelers, and also that he is the national director of the CDC-sponsored Global TravEpiNet program. The program has been incredibly successful. He'll probably say a few words about it, and they've done some fantastic work. And so with that, there's just so much about Ed. I can't say it. He's a fantastic speaker, great colleague, great friend. So he's going to talk to us about treatment of malaria in a non-endemic region, and then we'll move over to Catherine Tan. Okay, thank you.
Christina, thank you so much for the kind intro, and it's wonderful being with you all today. And let me go here. Hopefully you are seeing my screen, and hopefully it is on presenter mode. Is that correct?
Looks good.
All right. So we'll spend about a half an hour going over treating individuals with malaria in a non-endemic area, just with the major aspects, and then we'll turn the floor over to Dr. Tan to take us through some of the CDC's perspective. I have no COI, and if anything's off label, I'll point it out. So 2 cases, 42-year-old male born in Nigeria, in the US for 16 years, returned to Nigeria to visit family. So the CDC terminology for that is a VFR, visiting friends and relatives. Those are highest risk for a whole slew of infections, including malaria. And the individual went back to Nigeria to visit family for about 4 weeks, had a wonderful time there, did not seek medical care before the trip, which is the most common. Only about 35% of individuals seek care before they go international. And largely the VFRs don't seek care because they're going home, they're not concerned. The individual reports malaria and typhoid multiple times as a child in Nigeria, now works in IT in the United States. Had a wonderful time, did well after coming back, got no shots, took no medicines. About 3 weeks after coming back into the United States, started having chills, muscle aches, headaches, some loose bowels. After about 3 days of feeling punky, seeks medical care. You see him afebrile, soft blood pressure, close to tachy, a bit dehydrated, no rash, lungs clear, no organomegaly, no lymphadenopathy, no rash. So we don't have time today to go through the differential diagnosis of this. This is a malaria talk. So the main thing here is malaria can present non-specifically. And just with the history of chills and back from Africa, malaria should be high on your list. If you watch this guy over the next 6 to 18 hours, he's going to have a fever on you. And so don't assume just because he's negative in your office or you're in emergency room or urgent care, that if he doesn't have a fever, that it's not a febrile illness. It's a bit long for arboviruses or some of the other things, so let's just focus on malaria for lack of time. You do some blood tests, and he's a bit wacky. He's hyponatremic. His bicarb's down to 15, so he's probably acidemic. GFR is down, Billy's up, platelets down, but nothing too out of whack, but these are obviously abnormal labs. So what do you want to do at this point? You don't even have a firm diagnosis. Even though there's no history of fever here, Obviously, for somebody 3 weeks after coming back from Africa with chills, etc., you're going to send blood cultures. You're going to look at a UA to look for anything consistent with lepto. You're going to send a malaria test. I'll come back to that in a second. And just FYI, this is not somebody you want to send home from your office, right? If you think about it, those labs are wacky in a 48-year-old healthy person. And within a month of coming back from Africa, you really have to figure this out before you figure out how you're going to dispo. So it says malaria is on the list. What do you want to do to figure this out? Most labs are using the rapid test, the lateral flow test. And so the one that's FDA approved in the United States is this one. It's like a pregnancy test, a Binax now. A lot of labs no longer do thin and thick smears, or they don't do them on a regular basis because of the buffers have to be made, and it takes expertise and time. So many of the labs do these rapid tests, and this person comes back with Plasmodium falciparum. You can see there's 2 bands here, a control band, and then the pattern is consistent with Plasmodium falciparum. Usually that reflexes the lab to go ahead and do thick and thin smears. The thin smears confirms the diagnosis and tells the lab also what the level of parasitemia is. Some labs will go directly through this. Do not send malaria PCR. Do not send malaria antibody tests. I'm amazed at how often I see that being sent. They have no clinical utility for this diagnosis. You either want a rapid test or you want a smear. And here you see classic morphology associated with falciparum, with sort of the headphones, the oblique manifestations, and the ring trophozoites. So how common is this? As Dr. Coyle alluded to, this is the sweet spot. This is a fastball over the plate for you. Falciparum malaria is the leading cause of malaria in the United States. New York City is the epicenter of malaria in the United States. The amount of malaria is going up in the United States. The people who present are usually coming from Africa. They usually present in the summertime, and they usually are VFRs. So everything, this is a fastball over the plate for you. And then with regard to time, 90% of FALCIP will present within about a month of the trip and exposure, and about 95% will present within 3 months. So if you have a fevers or chills within about 1 to 3 months of international travel that may have exposed to malaria, you should be thinking as FALCIP as the leading guy coming down the pipe. If you noticed here, and these slides will be made available to later, but if you look, Vivax and Ovali come out over the next 3-4 quarters as well. But also by the end of 1 year, you're up to about 90 to 99% of malaria will have presented. So obviously think about it if someone's 5 years out, but those would be exceedingly rare. I don't want you to miss common things are common. Fevers or chills within a month to 3 months of Africa till proven otherwise is malaria, and up to a year or so from anywhere in the world could be malaria. So let's go back to this patient. The lab says, oh, there's about 1.7% parasitemia. You confirm falciparum. Do you admit it or not, and how do you treat? I'll just make it simple for you. Don't fine tune it. Admit falciparum in the United States until you gain control of the infection and make sure the person is on the right medicine. It's just not worth trying to send them out and then searching from pharmacy to pharmacy to pharmacy, et cetera, et cetera. It's just going to burn you and it's going to hurt the patient. So admit falcip in the United States. And these are the questions that you should ask. What's the malaria species? Where was it acquired? That'll tell you resistance probabilities. What's the parasitemia level? Is this person immunologically naive, or do they have partial immunity? Do they qualify for what's called severe or complicated disease? Do they have comorbid conditions? And what are some of the collateral issues, home situations, insurance, and all that sort of stuff? Because that'll be practical for trying to figure out how you're best going to treat the person. This is just to remind us that not all areas of the world are malaria equal. The majority of malaria that's the burden around the world is in sub-Saharan Africa. And obviously this area over here in Oceania in Southeast Asia is also another hotspot. This takes into account, this is a representation of some of the CDC data. It takes into account that when you go off to Africa, your risk, if you don't take anything, is about 1 to 2% per month. In these areas, maybe about 1% per month in these areas, maybe 2 or 3% per month over in the Papua New Guinea area. But then you work your way down. By the time you get to sort of very low risk zones, you're down to 1 in 100,000 per month if you don't take anything. So you have to stratify this risk. And what I don't want you to miss is these areas of the world, although any malarious area can obviously put the person at risk. Your friend in this is the CDC. The CDC Yellow Book is free online. You can get it any time of the day. Just type in CDC Yellow Book. You can go to the table of contents. You can put in the country you're interested in, and you'll get the malaria map for there. So obviously Brazil has malaria, but the malaria zone is really the Amazon basin. There's lower risk zones that harbor that. And there's other risk zones that we don't really worry too much about malaria. So this will fine tune it. The CDC Yellow Book also helps you. Let's just pretend you have somebody back from Thailand or whatever. You can actually check what's the breakdown of species there. Oh, in Thailand, it's about 50% FALCIP and 50% Vivax. It'll also tell you what your resistance profiles are for that. It's chloroquine and mefloquine resistant. So obviously, if you're going to treat somebody back from Thailand with malaria, you want to know those facts, and you want to know if you're going to treat for, say, FALCIP, that you can't use these agents, et cetera. So these are all freely available at your fingertips. Obviously, there's a lot of resistance out there, and that we worry about. There's increasing resistance, not only to FALCIP, but there's relatively chloroquine resistant or tolerant Vivax as well. And we'll come to that in a second. We are making progress globally. The dark blue countries are countries that since 2000 have eliminated malaria. The lighter blue countries are the countries that have decreased malaria by at least 75%. But there are some countries like Venezuela, et cetera, where the stats are going the wrong way. And obviously, there's some areas of the world in sub-Saharan Africa where there's no even data that can go on this map. And although some control is being made, it certainly hasn't been gangbusters. This is to remind us there's a couple of malaria species. Here's the risk zones for falciparum, and here's the risk zones for Vivax. So obviously, somebody coming back from Africa, FALCIP is going to be more likely. Coming back from this area of East Africa, Vivax will still be in the running. In Latin America, it can be FALCIP, but statistically, it's probably going to be a Vivax. And you can just see this. In India, it's probably going to be Vivax, although it can be FALCIP, et cetera. That just helps you keep your parameters. And the reason why geography is important is because geography not only dictates risk, but geography also dictates resistance profiles. And so what you see here is there's some areas of the world where we have mefloquine resistance and chloroquine resistance. The hottest zone for worrying about those things for falciparum is over in Southeast Asia. And these areas have wide resistance, including to mefloquine. And now there's delayed artemisinin clearance, et cetera. So have respect for people back from these areas of the world specifically. With regard to our first patient, Nigeria, you can clearly see that the majority is FALCIP out of Nigeria, and it's chloroquine resistant. So we know these stats. He's 1.7% chloroquine resistant FALCIP malaria. Beware of 5%, and I'll come back to that. He probably has partial immunity because he lived there for many years, but he's lost his immunity, but he has partial. So you have a bit more of a buffer zone in approaching him. And then the question is, does this qualify for severe or complicated malaria? And here's the simple list of that. And you can see this on the CDC listing of how to get Artesunate. And it's pretty clinically straightforward. Are they having seizures? Are they comatose? Are they in circulatory collapse? Are they in acute renal failure? Are they in DIC? Some of these are common sense clinical things. 5% is used because because we only see the tip of the iceberg with falciparum. So if they have 5%, actually there's much more because most of the infected red blood cells are in the post-capillary venules. For those of you who are more numbers based, here's the WHO listing that you can get from UpToDate or other locations of the WHO website of what actually qualifies for persistent acidemia and hypoglycemia, et cetera. But at the end of the day, just use your clinical gestalt. Don't treat the numbers, treat the patient. All right, so let's just do another patient so we can get some parameters around this. Here's a 50-year-old woman who is a U.S. native who presents to the emergency room. She was brought in from the airport, dysphasic and disoriented at the airport. She was afebrile. She appeared okay to exam. They were thinking she was having a stroke, but her labs come back really wacky. Hyponatremic. She's in acute renal failure with a creatinine of 4. She has Billy's of 4 and 7. She's thrombocytopenic to 34. She's anemic to about 30. And so she's very wacky. And so obviously, and her blood smear shows falciparum malaria. In her case, she was only here for a quick business trip. She had just come from India where she was on a business trip. And the week before that, she was in Nigeria on a business trip. She took no chemoprophylaxis because she traveled extensively. And her friend didn't report any fevers, but the friend said that she had a persistent headache for the last couple of days. So here's a woman who's obviously in severe malaria. She had 7% parasitemia. She was neurological manifestations, renal failure. Binax is positive. We recommended dropping an NG tube and giving her artemether lumefantrine. We'll come back to that coartem. And then we requested CDC. This was right before it went commercially available for IV Artesunate, and she was admitted to the MICU. She needed to be intubated, pressor support, CVVH, pulmonary edema, acute renal failure, muddy brown cast. She was in shock. She necrosed. She eventually survived. Her mental status, we were able to get her through. We eventually extubated her. We eventually got her off CVVH. But she is a classic case of severe malaria. So those are the two spectrums that you have to figure out. So what do you do? At the end of the day, one of the things I want you to take out is you really should be artemisinin based in your treatment. All right, that's the main thing. I don't want to hear of, oh, we don't have it on formulary, et cetera. A lot of you ID docs, call your pharmacy if it's not already on your formulary. You should have the ACT, the artemisinin combination oral therapy, on your formulary at your hospital. You are New York docs taking care of New York patients with the highest risk of malaria. This should be on all hospital pharmacies for the oral agent. And then the IV artesunate is for the severe, and this is now commercially available. These should be your front two drugs. If you're at a hospital and you still don't have them, for uncomplicated falciparum malaria, you can use atovaquone proguanil to hold the line. It's technically FDA approved for that, but I'll show you some data that the artemisinins are the best drugs. And if you're really back to the wall, you have nothing and you're just looking around what you can throw at the person before they die, you can do mefloquine. All right, but you really don't want to do that because they're going to psych out on you at the end of the day. But those are for you're at a hospital, your back's to the wall. I really want you to get Coartem on your formulary, and I want you to get IV artesunate on your formulary. And why? It's because it saves lives. Our best drug for bad malaria is quinine, actually, better than those other drugs historically. And so here is the Aquanaut study, which was a classic in the field, and it showed by every metric that people looked at, the artemisinin, that artesunate was better than quinine for severe malaria in kids, including mortality. And you say, oh, that's kids in Africa, etc. Here's Southeast Asia, here's Sequemat. And also, once again, artesunate has a mortality benefit and by all the metrics. The artemisinins are the frontline drugs. They clear the parasites the quickest and they have a survival advantage. So you really should have these drugs on your formularies. If you go to the WHO, for uncomplicated malaria, they recommend ACTs, artemisinin-based combat therapy. For non-immune travelers, they recommend ACTs. And for treating severe malaria, they recommend artesunate. So these drugs should be on your formularies. Don't let your formularies tell you, oh, let's use crappy drugs where we have less survival just because it saves a few bucks. All right, so get them on your formularies in New York. On the IV artesunate, Dr. Tan will take us through this, but there's a CDC webpage. It's available both through an IND, but now also commercially available. We've added this to our formulary. We've already placed our order and had for bringing IV artesunate on at Mass General here. IV artesunate is the frontline drug for people who have severe disease. There's no renal or hepatic adjustment because many of these patients will have hepatic and renal insufficiency when you're trying to save their lives. The medicine is given, as you list here, over 3 dosages. You then check your level of parasitemia. If it's not less than 1%, you redose them and you continue to a max of 7. You follow your parasitemia, I'll come to that. And once it's less than 1%, then you switch to an oral regimen, in which case it would be an ACT. Coartem would be our frontline drug. How often do you check malaria smears? If it's severe, it should be every 12 hours for the first 2 to 3 days. You're following to confirm a response, to your treatment. If it's uncomplicated, it should be daily. That's another reason not to send them home, because you want to make sure you're going the right way with the numbers, etc. Then you check daily until they're negative, and you repeat then at day 7 to confirm that you actually have put the nail in the coffin. If they're non-immune and the parasitemia is greater than 1%, 4 hours after the 3rd dose, then keep going, give them another course of the artesunate until you get them less than 1%, then you switch them to oral. And then you complete a full oral course after you complete the IVs. The IV artesunate is associated with a post-treatment hemolysis. So everybody who gets treated with that has to have they have to be seen in office or a blood test once a week with a weekly CBC for 4 weeks after you do that. What do you do in pregnancy? Here it is. First of all, pregnant women have a bad time with malaria. They're more likely to develop hypoglycemia, more likely to die, more likely to have fetal demise, more likely to have pulmonary edema. And so if it's severe, which many of them are, you do IV artesunate followed by a PO artemisinin combination therapy. If they're not severe and it's chloroquine resistant, you could consider, per the WHO, quinine and Clindon the first trimester. That's just a historic holdover because that's what was used, the only drugs in town for a long time. And so that's the best safety data in that. But to be honest with you, if it's severe, you're going to Artesunate anyway. But recognize that quinine in pregnancy often is associated with severe hypoglycemia. And so you really have to follow their glucoses every 4 to 6 hours if you're going to do that. I personally would still go ahead and treat with Artesunate and ACT, but I just wanted to tell you the WHO recommendations. If it's not severe, pregnant, and chloroquine susceptible, you can easily reach for chloroquine, but you better be damn sure it's chloroquine sensitive malaria before you do that. And we'll come to that in a second. So who has chloroquine sensitive malaria and who is uncomplicated? And those are basically, if it's malaria from Haiti, the Dominican Republic, falciparum malaria, which is what they have on the island, Haiti, the Dominican Republic, Central America, west of the Canal of Korea, you could, if it's uncomplicated malaria, you could treat with either chloroquine or hydroxychloroquine. But you better be damn sure of that, because you don't want to miss that treating. Undertreating is what I'm getting at. If you don't know which species you have, treat as falcip. If you don't know your resistance profile, treat as chloroquine resistant. If you fall back to ACTs and Artesunate, you will treat everything. These are some of the things I want you to be particularly aware of. These are some of the things I want you to be particularly familiar with falcip. Obviously, neurological changes can tell you going into cerebral shock, and a good persistent shock. And people who are at particularly risk of that is people who have persistent low bicarbonates, evidence of acidemia, because it means they're not getting tissue perfusion because they're sludging in their vasculature that you can't quite see. Obviously, that can happen in the lungs, and you can develop pulmonary edema. In pregnant women, you can get placental malaria, and then renal failure with black water fever, either from the malaria itself with the high parasitemia, perhaps complicated by the IV artesunates. And so on that, we usually just put them on high flow normal saline. There's some data that bicarb will help speed it up, but sort of treat them like a rhabdo is the best way to do that if you do get that. All right, here's a poor girl who has cerebral malaria. She's sludging in her brain and getting punctate hemorrhages. Here's a young girl who has pulmonary malaria. She's sludging in her pulmonary vascular. Why does falcip sludge? And we don't have time to do a lot of pathophysiology, but an infected red blood cell, here's a parasite, here's an infected erythrocyte. They develop these knobs on the outside, and this is a survival strategy. This parasite's trying not to go through the spleen, and so it's docking into post-capillary venules, and that's why when you see 5%, that's bad, because that's the tip of the iceberg. This sludging is occurring all over the body, and there's tissue hypoperfusion, etc. All right, so non-falciparum malaria, what do we do with that? So those are either Vivax, Ovale, Malariae, or Knowlesy. They don't dock in the post-capillary venules, so as a general rule, what you see is what you get. If you have 3% parasitemia, it is 3% parasitemia, etc. Some of them go for young blood cells, some go for old blood cells, some go for all different ranges. And so if you can't confirm which diagnosis you have, treat as falcip. If you can't confirm resistance profile, treat as chloroquine resistant. Some of these will sometimes go severe, especially the Vivax or the Knowlesy. If you do get that, treat it as severe malaria like you would a severe falciparum. And if it's a mixed infection, we sometimes see that because people get a fever from their falcip and then they reactivate the Vivax in their liver as well from it's almost like a fever blister. They'll sometimes come in with more than one malaria. If that's the case, treat for falcip and it'll mop up the other one as well. So if you have uncomplicated non-falcip malaria and it's chloroquine susceptible, you can treat with chloroquine or hydroxychloroquine or an ACT. No one's going to stop you from treating with an ACT, but you do have these other options. No matter which one you do for these two, for Vivax and Ovale, you have to give an anti-relapse medicine. I'll come back to that in a second, or at least consider it. And there's some places in the world where there's going to be chloroquine-resistant Vivax. And those hot areas of the world with PNG, Papua New Guinea, the Indonesian, Papua, the province in Indonesia, the Sabah province of Malaysia, and the South Sumatra province in Indonesia. Those areas often are chloroquine resistant or chloroquine tolerant. So I would almost treat, if anybody had a Vivax back from here, I would actually default to ACT de facto. Parasitemias, when you have a non-falcip malaria, parasitemia should fall by at least 75% by day 3 and should be undetectable by day 4. If not, you have to think you might have a resistant strain and you should switch your medicine, etc. Usually check daily until clear, and then you check them 1 and 4 weeks later. What do we do for Vivax and Ovale that have the liver hypnozoites so they can relapse? Remember that figure we started with at the beginning? 10 or 15% can come out in each quarter. What's actually interesting, if you have a confirmed case of Vivax or Ovale, about 50 to 60, even if you treat them, about 50 to 60% of people will relapse over the next year. It's actually quite high. And so you have a couple of options there. If you want to clean out the liver, the medicines we usually use are either Primaquine, that's been around used widely since the Korean War, or Tefenaquine, which is the newer kid on the block. These are drugs that will clear out the liver, but a couple of things: never use them in pregnancy, even if the mom is G6PD normal, because the baby might not be. Never use it if the baby's younger than 6 months of age, because they can't tolerate it. And don't give it to a mom if she's breastfeeding to a younger than 6 months of age, because they can get across in the breast milk. You also have to confirm that the woman won't get pregnant if you give this medicine while you're giving it to her. And you have to confirm that there's a normal G6PD. Efficacy relates to total mgs per kg, and there's all different regimens that you can use. I've listed here what's the most common one. What to say on the G6PD, let me tell you about that. There's two types of tests that your labs might run. There's a quantitative and a qualitative. The qualitative is basically a binary. It'll tell you whether it's greater than equal to 30% of normal G6PD enzymatic efficiency. And if you're greater than 30%, you will usually tolerate these dosages that are listed down here of Primaquine. If you're less than 30%, you'll be listed as G6PD deficient. If your lab does a quantitative test, they'll actually give you an actual percentage. And so if somebody's between 30 and 70%, there's regimens that once you confirm that you can give, and we consider it totally normal if the person's greater than 70%. So some experts, if you confirm greater than 70%, will front load the person over 7 days to make it more likely they're going to finish the regimens. But the de facto one that you usually use is to treat with this regimen, which is 0.5 mg per kg of the base, Q day times 14 days. If they're less than 30%, we consider that person G6PD deficient, and you should not use these medicines. You have a couple of options. And well, some experts would say you can give them a low dose, or you can give them a weekly dose for 8 weeks. I personally just wouldn't do that, but you can do that if you wanted to. And that just gives them a low-level hemolysis over a longer time period. What you can also do is you can just observe them and tell them, you know what malaria feels like. You have a 50% chance over the next 6 to 12 months, you're going to get it again. As soon as you have fevers, headache, and chills, come on in and we'll give you another course of chloroquine or whatever it was. Your other option is you can actually give them weekly chloroquine like they're traveling on a trip. And you can do that for the duration, say, of their pregnancy, or you can do that for 6 or 9 months, technically, if you wanted to get them through that time period, not worrying about the Primaquine hemolysis, and you'll get them through the vast majority of their risk of relapse. Obviously, if you give them any of these drugs, Primaquine or Tefenaquine, you should follow for hemolysis, and you should make sure you tell the patient to beware of shortness of breath, fatigue, jaundice, or dark urine, all of which are signs of hemolysis that you have to worry about. The newer kid on the block is Tefenaquine. There's two, just FYI, there's two commercially available. I have no association with either of them. There's Crintafel, which comes as 150 milligram tablets, FDA approved in the United States for the treatment of individuals greater than 16 years of age with Vivax to prevent relapse. There's another Tefenaquine, Aracoda, which comes in 100 milligram tablets. That's FDA approved over the age of 18 for prophylaxis of it. So if you're going to do this and you want to work on label, you would write them for Crintafel, and basically it cuts the risk from about 50 to 60% down to 20, 30%. But all those stipulations we talked about before, not pregnant, normal G6PD, and it's FDA approved for Vivax, although people would also use it for Ovale, although you could fall back on Primaquine. And this just wraps up. CDC is your friend. You have the yellow book. It tells you all the info. There's 24/7 individuals available. There are individuals like you have Dr. Coyle in New York. There's many individuals in different cities who do have expertise as well. You have Dr. Daly in New York. You guys are blessed down there. The main thing is to prevent, right? And especially if you want the sweet spot, if you have in your practice someone who was born and raised in Africa and might go back and travel there at some point for their brother's wedding or their father's funeral, or to go back and visit, that's low-hanging fruit. You should really talk to them and say, oh, before you travel back to Africa for any indication, make sure you call me and I'll make sure that you take the malaria pills, etc. This webinar is part of a three session one. And I know Dr. LaRock will be talking to you in a future one on how to actually go through this prevention in more detail. but an ounce of prevention here, both those two individuals could have been easily prevented from getting malaria by just taking a prophylactic medicine while they were traveling. And both of them would never have needed